Facilitating this session, just facilitating. And we have a series of activities during this health forum. Before we proceed, please, I'm kindly requesting you to come and sit at the middle. These two columns, it will be good. Please, the ones who are seated behind, please, if you don't mind, kindly come and sit to this column, this and this column. I'll be waiting for you. Thank you so much. Oh, okay. Okay, thank you. So we all know why we are here. We're here for the Health Forum for family planning for adolescents and young mothers. And before we go to our detailed panel discussion, we'll have a video where we are going to see testimonies from first-time mothers that have been exposed into our community approaches for family planning, but also we'll listen to the evaluation findings for this family planning program from Save the Children, and then we will hear the panel discussion with different panel staff. So why is it interesting to discuss about adolescent young mothers family planning program? We all know that adolescents is the age that is vulnerable, but also they incur rapid pregnancies during their young motherhood. And also we know that there are various programs, but most programs, either they have not been piloted or it's difficult sometimes to scale up these programs. But as for this program has been piloted and it has been also scaled up. So we have evaluation findings that we think that if we look into it, it will be helpful for us to understand on how we can scale our community and health facility approaches for improving family planning uptakes. And so I would like to welcome the studio to show us the video to see these first-time mothers from Dodoma and their testimonies about their exposure to this program. Welcome, studio.
Over the past 5 years, the Connect project has been dedicated to improving postpartum family planning, or PPFP, among adolescent and young first-time mothers aged 15 to 24 in Tanzania. During the 5-year period, the project has been able to reach 61 villages in Bahi and Kongwa district councils of the Dodoma region.
Kwenye mradi wa Connect, mbinu kuu ambayo tumeitumia kuwapata walengwa ni kwa kutumia hao wahudumu wa afya ngazi ya jamii, ambapo baada ya kuwapa mafunzo tuliwapa jukumu la kuja kufanya sensa katika jamii yao ili kutambua hawa mama vijana wenye umri wa miaka 15 mpaka 24 wapo katika kaya zipi.
Kwa mama kijana ninawaelimisha juu ya uzazi wa mpango na lishe kwa ujumla na mambo ya ujasiriamali.
To ensure that first-time mothers have easier access to the postpartum family planning services they need, the Connect project collaborated closely with local health facilities in the Bahi and Kongwa districts and provided training and resources to healthcare providers, equipping them with the necessary skills and knowledge to offer comprehensive postpartum family planning services, which promotes gender and respectful care across reproductive, maternal, newborn, child and adolescent health.
Katika mafunzo walitumia miongozo ambayo iko ya Wizara ya Afya, wakapata yale mafunzo, lakini pia kuhakikisha kwamba huduma sahihi inatolewa. Tulifanya usimamizi shirikishi kwa kushirikiana na wadau wetu.
Ule muunganiko ambao umetengenezwa na mradi wa Connect kati ya wahudumu wa afya, zahanati na ngazi ya jamii umekuwa ni mkubwa, kwa sababu yeye atatafuta wateja, mimi nitakuja nitahudumia, mimi nitatoka hapa nitaenda kwenye kikundi chake na vitu kama hivi.
These young women face the challenges of early motherhood without guidance on how to plan for their futures and they are often without prior knowledge of family planning options.
Nilipofika la 7 mwezi wa 9 nikapata ujauzito. Sikutambua kwamba nilikuwa na ujauzito. Nikaendelea na masomo, nikaenda form 1. Nilipofika mwezi wa 3 ndio nikatambua kwamba na ujauzito. Penina ndo akaniita akanisema kuna mradi, ndo akaniandikisha, ndo akaanza kunifundisha mafundisho ya Connect.
Kwa kipindi cha nyuma ukuta mtoto anayefuatana mtoto mwenzake kwa muda wa mwaka mmoja, miaka miwili ilikuwa ni kawaida, lakini kwa hivi sasa mama ambaye ni kijana amekuja labda ni mimba ya pili, ukimuuliza mtoto wake wa mwisho ana umri gani, ataanzia miaka 4, 5. Kwa hiyo tunaona effect ya huu mradi.
Nisingekuwa kwenye mradi wa Connect, ningekuwa kwenye makundi mabaya sana. Sasa hivi ningepata tena mwingine. Afya yangu ni njema na mwanangu afya yake ni njema.
Through household visits and family discussions conducted by community health workers or CHWs, the project has strengthened the engagement of first-time parents and their families in the decision-making process regarding postpartum family planning. This initiative helped to address common concerns and misconceptions about family planning in the community, which led to first-time mothers' parents understanding the importance of family planning for their daughters' health and well-being.
Mhudumu akaja akanieleza, nikaona vema, sikuondoka. Tulizungumza vya kutosha. Mwibindi akasema hapana, nitafuata ile njia ambayo naifundishwa sasa hivi. Hiyo itanitosha kwa mimi. Nikasema asante.
Mimi nimejipanga vizuri kumtunza mtoto wangu. Baada ya miaka 5, 6 ndo nipate mtoto mwingine.
The Connect project has been pivotal in addressing common myths and misconceptions about family planning within the communities it serves.
Mtoto wa kwanza nilimpata nikajiunga kwa njia ndefu, yani kipandikizi. Nikakitumia kile, nikaona akijaniletea shida yoyote hadi mtoto wangu kaja kufikisha miaka 3. Pale nilipopangilia kupata mtoto nikapata. Na naamini tena nikihitaji watatu napata.
The project has helped to break down traditional gender barriers and promote a more inclusive approach to reproductive health.
Kabla sijapewa mafunzo, sikuwa tayari kabisa ni kuingia kwenye uzazi wa mpango kulingana na yale mambo niliyokuwa naambiwa na wenzangu.
Baada ya kuja kutelimisha ndipo nilipokea vizuri tu. Tulishauriana na mke wangu kwamba tuanze kutumia uzazi wa mpango na tuongozana moja kwa moja hadi kwenye kituo cha afya ili kupata uzazi wa mpango, kuanza kutumia rasmi.
Zamani mwanaume kuja kumleta mkewe kwamba amekuja kwa ajili ya uzazi wa mpango ilikuwa ni nadra sana. Lakini leo hata wiki iliyopita tu hapa nimepokea wanaume nafikiri 3 wamekuja kwa ajili ya kuchukua vidonge kwa ajili ya wake zao.
The project has also created opportunities for first-time mothers to learn, grow and support each other through the creation of income-generating groups facilitated by community health workers. These groups serve as a dual platform for learning about postpartum family planning and gaining of entrepreneurial skills.
Hapo mwanzo kulikuwa kuna changamoto za kuhudhuria. Kwa kutokana tulivyoweka ujasiriamali wa kukopa na kukopeshana, ndio tukavuta wengi wakaongezeka, kutokana wanaona nikienda napata elimu na kitu narudi nacho mkononi. Kwa hiyo hicho nacho kimetusaidia kuongeza idadi ya washiriki. Wameweza kuinuka kiuchumi na kijamii kwa sababu walifundishwa sio masuala ya uzazi wa mpango peke yake, lakini pia walielekezwa na namna ya ujasiriamali, namna ya kujikwamua kiuchumi kwa kutengeneza bustani ndogo ndogo au aidha kufanya biashara ndogo ndogo.
Mradi wa Connect ulivyokuja ulitusaidia, kwanza tuliweza kufikia eneo kubwa, lakini pia ukiangalia takwimu zetu zimepanda. Kwa mwaka 2021 tulikuwa tuna 16% ya kina mama wanaopata huduma ya uzazi wa mpango mara baada ya kujifungua. Tumetoka kwenye 16% mpaka kufikia 43%.
Ama kweli nimeamini uzazi wa mpango baada ya kujifungua, lishe bora, familia bora.
Nilipokuwa nasikia uzazi wa mpango ilikuwa geni kwa.
Asante sana. Asante sana. So those are first time mothers from Kongwa and Bahi districts in Dodoma region. I hope you've heard from them. So after this video, I now welcome the Connect lead and Dr. Elsaria to give us a presentation on the key findings from the program, from the evaluation. Lillian, you're welcome.
Asante, Victoria. Good afternoon, everyone. Yeah, I'm here with my colleague, Dr. Esther. She's going to take us through the impact evaluation findings of our community-based interventions on PPFP among first-time mothers. But before going into the finding part, I'll just take you through the overview of the Connect project so you can link what you hear with what we do at the community and facility level. Next slide, please. Yeah, so our project is called Connect, and our goal is to develop, evaluate, and document scalable approaches to increase the use of postpartum family planning among adolescent and young first-time mothers between the age of 15 to 24 in order to improve birth spacing and maternal and neonatal outcomes. And we are using innovative approaches which are light touch. We call them enhancements. They leverage existing health and community systems. So our enhancements, they are not standalone enhancements or interventions, but they enhance or they improve or they leverage the existing platforms. And our project is in Dodoma. We started as a pilot in Kongwa district, and we did as a rapid assessment to inform our scale-up strategy, and the findings were very promising, and it identified our scale-up strategies where we chose Bahi district as a part of scale-up coverage. And we have a number of implementing partners. So this project is implemented by Save the Children Tanzania, and we have a local CSO, which is Taher, is doing implementation at the community level. And we also partner with our international Save the Children in US. And we have our research partner, who is George Washington University, who is leading the quantitative evaluation piece. And we are getting financial support from Bill and Melinda Gates Foundation, and the project started 2019 and it will end this year, 2024. Next, please. So before we design our approaches, we conducted a formative assessment to identify key barriers to PPFP uptake among young mothers. And these are some of the key barriers that young mothers at the community level, community and facility level, are facing. So we found out that they have limited decision-making power regarding their fertility and reproductive health, but also they experience harsh and judgmental treatment from providers. And we also found a number of missed opportunities to integrate family planning, but also to reach the young mothers at the community level. And we found profound myths and misconceptions about modern family planning. So we designed our approaches to address these barriers with expectation that we'll be able to increase or improve their PPFP uptake. And we are doing so by strengthening inclusion of first-time mothers into community outreach efforts, such as home visits and community support groups, but also engaging family, household and family influencers to build support for first-time mothers and to improve knowledge about family planning. But also we address issues of gender and respectful care at the facility level. Next. So our interventions or enhancements, they address facility and community barriers. And at the facility level, as I've said, our interventions are enhancing the existing platforms. So we know that we have national guidelines for gender and respectful care, and what Connect did is to support Ministry of Health to develop gender care on the job training for facility-based providers to address issues of gender and respectful care at facility level. But at the community level, we were enhancing our USAID Lishe and level project, which was working with community health workers. And what we added into the Lishe and level interventions, we increased enrollment of young mothers into support groups for nutrition, for breastfeeding mothers, pregnant and breastfeeding mothers, but we also added 4 PPFP activities with different family planning information and themes during community support group sessions. And we also introduced home visits into Lishe and level interventions to first-time mothers, which community health workers visit the young mothers at their household, and they provide integrated PPFP and nutrition counseling, but also they provide PPFP referrals for facility, and they provide family planning commodities such as condoms and oral pills for those who are refilling. But also for home visit is the platform where male partners and other family influencers are engaged if they are available during the discussions to increase their knowledge and build support for young mothers to uptake the services. So in a nutshell, those are how our interventions work, and those are the interventions where we conducted impact evaluation to see if they have any significant contribution to our desired outcome. Asanteni. May I welcome Dr. Esther to take us through the next step.
So good afternoon. Thank you so much, the presenter, and thanks to Save the Children. Thanks to George Washington University for the trust. But I also have to thank my director who is here. He can wave around, Professor Honorati Masanja, who has mentored me for 13 years. So whenever I'm standing here and he's available, I feel blessed. So thank you so much. So my colleague has just presented the design that this Connect project utilized the existing infrastructure, and that was the Lishe and Level project and implemented in Dodoma. And they utilized the community support group and the community health workers to reach the first-time mothers at the group and also at home. So myself and the team from George Washington University, we supported the evaluation of the project. So here we are now going to present the part of the evaluation. So thank you so much. So next, please. So overall, the purpose of the evaluation was to bring into the evidence around the scalable and efficient approaches to increase the use of modern postpartum family planning among the first-time mothers who are aged 15 to 24 years in Kongwa and Bahi in Dodoma. And as she mentioned, the Kongwa and Bahi and also Dodoma overall was selected because at that time, especially on the DHS 2015, the prevalence of teenage pregnancy was 39%. And for the DHS was 27% overall in Tanzania. So it was 27, but in Dodoma specifically in 2015, the teenage pregnancy was 39%. And that was the purpose why Dodoma was targeted for this evaluation. So during the evaluation, we assessed the main 2 things. One was the adoption of the family planning, and the second is whether they continued using the family planning. So we were having those 2 main objectives, but we also had the secondary objectives. Next, please. So those are the sites where the evaluation and also the project was done. So that's the map for the Tanzania and the map for Dodoma. So the project was implemented in Kongwa and Bahi because that's the area where the Save the Children Lishe Endelevu was doing the intervention. So we anchored this project, the Connect project, into the ongoing Lishe Endelevu, showing the robustness of even integrating these two approaches to increase the uptake of family planning use. Next. So the evaluation was basically a cluster randomized control trial where the villages were randomized to either receive the Connect project or to be in a control site. So we had two groups, either in the Connect or either in the control group. So for the control villages, they continued receiving the standard care from the health facilities. But for the Connect group, they received the standard care together with the Connect package, where they had the community support group sessions, 4 sessions, and they also had a follow-up from the community health workers at the village, at their household level. So, but for the all facilities, both in the control and the intervention, we had a training, on-job training of the health workers on the respective maternal care. So they all benefited in the control and the intervention on that component. Yes, next. So as I mentioned earlier, we had 2 main outcomes, the adoption and the continuation. So for the adoption part, we really wanted to understand whether these mothers will adopt the modern method within the first year of after they give birth. But we also wanted to know whether they will continue using, because you can adopt and not use, but we wanted to know that they adopt and they continue using the family planning method. But we also had secondary outcomes. So the secondary outcome, we also had the intention to adopt, the satisfaction, discussion, whether they will discuss with the partner about the use, the self-efficacy, knowledge, and attitude. So those were the secondary outcome of the evaluation. Yeah, please, next. So for the baseline happened around February and March last year, and we recruited around 1,134 first-time mothers who were aging around 14 to 25 years. And the end line happened this year around June, July. And we managed to follow up the same mothers and achieved a 94.7 rate of tracking them. So at the end of the day, we had 1,070 women, first-time mothers who were followed at the end line. So for me, I consider this as a very strong tracking rate and quite rewarding. I can even clap for them. Thank you so much, Save the Children, for following them up. So in terms of the survey, because we had 2 versions of questionnaire, we had a full questionnaire and we had a short questionnaire. So for those who had a full questionnaire with all the questions, they were 1,025. And for those who did the short interviews, in case they moved outside the study area, so 22 of them were interviewed through the phone because they moved outside the study area. And 23 respondents, they used the short version of the questionnaire because they had stillbirth or they had miscarriage. So we felt it's too much to expose them with the long version of the tool while the child is no longer there. And they might feel, a bit of emotion. So we consider the emotional part of the aspect of this research. So next, please. So this is the baseline characteristics of the respondents at the control and the treatment. And you will realize that these groups were quite comparable for almost all the factors or the baseline factors before the Connect project was implemented, showing that the randomization worked very well and that was done properly. So we see the age range was the same, whether they are partnered or not, the age of the first marriage, or household size, child age. whether they were enrolled in school, the poverty likelihood ratio, the household, whether they have phone or not, the use of modern contraceptive, the facility birth, and all that. So all these variables were quite comparable. So when we did the analysis, we didn't see any significant difference between the two groups at the treatment and the control. See, this showed that the randomization really worked very well. So next, please. What is happening with the slide? They are shaking. So next, yeah. So this is the characteristics. There's something happening with the connection at the back. Hello, team. Yeah, so this is the sample characteristics of the endline group. So you'll see their age, whether they were partnered, whether they are in the relationship or not, the month since the first birth, you'll see that, the percentages. So those are the percentages at the end line, not in the control, but at the end line. This is the overall characteristics of the participants at the end line assessment. So you'll see there. I loved the aspect that the use of ANC services was nearly 100%, so it was 99.7%. So for the first child, and that is a very high rate of use of ANC services. And I will think that is, if we don't provide properly the family planning counseling at that point, is a missed opportunity, because the utilization of the service is pretty high, especially for the first-time mothers. So that is something we really have to highlight. So next, please. So then we assessed the impact of the Connect project. So we compared the postpartum use of the family planning method between the control and the treatment to look into if there is any difference between the two groups. And because the baseline characteristics were quite comparable, meaning that what we saw at the end was actually related to the Connect project. So we used the multiple linear regression analysis to analyze whether there is a difference or not, but taking into account several factors like maternal age, month postpartum at the end, the baseline measure of the outcome, baseline poverty likelihood, baseline partnership status, household head literacy, and also we looked into the potential imbalance that have occurred. So next, please. Yeah. So in terms of the interactions with the enhancement, you will see that in terms of the utilization of the community support group, 79% of the participants who were targeted attended at least one community support group. And for me, that is also a very high level of attendance. And for the targeted intervention, they had 4 activities, as I mentioned, and on average, they participated to at least 3.2 of those activities, and 60% of the participants attended at least all the 4 activities. So this was also a high level of utilization of the service. In terms of the home visit that was made by the community health workers, so nearly 55% received home visit, and 12.5% received either when they were pregnancy, and 97.5% of those who received the visit, that happened when they already gave birth. And the household that received home visit received at least 2.2 visits on average. And for the community support group meetings attendance, we did not see any difference between the older and the younger adolescents. Next. So this is the main findings in terms of the adoption and also in terms of the use of the postpartum services. So focusing on the sample who have children over 12 months, because when they were recruited, they were either have a first child or they were pregnant. So that's the time of the recruitment. So focusing on those who had children over 12 months, the Connect project increased the adoption of the postpartum family planning by 12.8% compared to the mean control of 57.6%. And that is equivalent to 7.4 percentage point increase. So when we restrict the analysis into who did not adopt any family planning at the baseline, you will see that the Connect project increased 21% of the use of modern family planning method as compared to the control, which was 53.4. But when we look into the overall sample size, so for all of them, the Connect project increased the family planning used by 12%, and it decreased the discontinuation by 27.5% as you compare to the control group. So this is a really, even though it's a short time, but this is a good outcome. Additionally, treatment increased the combined indicator of adoption and intention to adopt by 15.3% compared to the mean of the control, which was 57.4%. And that was equivalent to the 8.7% prevalence point. And we also observed that the Connect project increased also the early adoption for the first-time mothers. So you can have, next please. Yeah, can you come back again? Back. Okay, let's continue, yes. So in terms of the secondary outcomes, we observed that the first-time mothers had more likely to discuss about the family planning with their partners by 15.3% compared to the mean of the control. They were also likely to have high urgency in terms of whether they have to be pregnant or not. But we didn't see the urgency in terms of the type of contraceptive method they have to use. And also, 25% of postpartum mothers, the first-time mothers, experiencing just mild postpartum depression compared to those who are in the control group. So those were also some secondary outcomes. Next, please. So we also assessed the family planning knowledge using 6 questions. So these questions were yes and no. And we also observed that the treatment group had higher point of knowledge in terms of the family planning use and the method they have to choose than the control group. So we saw the 0.23 point higher in the 6th item of knowledge. Next, please. However, we did not see any significant difference in terms of the quality of family planning counseling. And we did not see any significant difference in terms of the self-efficacy score for the family planning. And we did not see any significant difference when to use the modern family planning method. So those results were not significant for this group. And we are exploring more to see why we didn't also see a reasonable effect for these factors. So we'll dig down more into the data to have the why part. Next, please. So the initial reflection, we have observed that the good exposure of the family planning at the community level and the use of community health worker, even though this was, we are saying, is a light touch intervention because it was just over a short period of time, but was able to significantly affect the primary outcome, that is the adoption and continued use. And we also saw that it has enhanced the use of the family planning for the first time. There was a graph, I didn't see where it just disappeared somewhere, maybe because of the internet, showing that the first-time mothers who were in the Connect adopted early on the use of family planning. And that is very necessary because even though looking into the mothers who are young, but even for the older women, getting the first pregnancy and the second is very close. So if you adopt early, meaning you're also delaying the possibility of being pregnant, and that is very important. But we also saw that this Connected project improved the knowledge and the ability to discuss about the use of the family planning, but we did not see much impact on the self-efficacy, the urgency on the use of family planning, and which method to use. Yeah, next. So this was the team. I think my colleague has mentioned. So much thanks to George Washington University, to my Ifakara Health Institute, to the EDI Global, who did the really massive work to collect the data, to the Thai Foundation in Bangladesh, and the Save the Children from the international to the local level, and to our funder, Melinda and Gates Foundation. Thank you so much.
Thank you so much, Dr. Esther and Lillian, for the presentation. So we now move to the panel discussion, and I now welcome Dr. Lynn from Save the Children. She will be our moderator, and she will also introduce our other panel speakers. Welcome, Dr. Lynn. A round of applause to her, please.
Asante sana. So on to a very exciting session. We've had the evidence. Now I want us to discuss the application of that evidence. I will be joined in this session by a panel of really eminent, distinguished, respected experts in the field. First off, Dr. Makuani. If you could just join us at the podium. Dr. Makuani is the Director of Reproductive and Child Health at the Ministry of Health. He comes with over 25 years of expertise, older than some people in the room. Not to say you're old, Dr. Ray, I'm just saying that you have a lot of experience. And he's led very many initiatives in the country, including RMNCH policies, service delivery, surveillance, maternal and mortality reduction initiatives, guidelines, all of it. Karibu sana Daktari. You will join us at on the podium. Next, I know it says there that we'll be joined by Dr. Ntuli, but we have a last-minute replacement. Dr. Ntuli will be replaced by Dr. Kengia. Now, Dr. Kengia is another esteemed colleague. He's the coordinator of research and publications at PORALG, and he has vast experience, more than 10 years, in primary healthcare. Karibu, Dr. Kengia. We will also be joined by Dr. Thomas. Dr. Thomas is another eminent colleague who's the district medical officer for Kongwa District Council, where one of the councils where this intervention was implemented. We will not leave behind one of the key stakeholders in this piece of work. Ms. Rosa Chimigai is an experienced community health worker with more than 21 years experience working in the sector and allowing us to really make sense of all this evidence that we keep generating and volunteering and working very hard to liaise with the communities. And we will also be joined by Gerald, who is the National Coordinator for Gender and Adolescent Health at the Ministry of Health. And Gerald comes with a lot of experience, which includes even the development of or supporting the Adolescent Health Services Barriers Assessment. So if you want to see him on the side to understand what the true barriers of access in adolescent health in Tanzania are for adolescents, please do see Gerald. So for my eminent panelists, karibuni kwa jukwaa. My apologies if jukwaa is wrong. Is it wrong? Oh, good. Sorry, I'm practicing my Kiswahili as well. So, a round of applause, tafadhali. Makofi kwao. And I'm thinking, let me join them and sit next to them as well. So it says there, Angela Kauleni, who is the country director. I'm representing the country director, so for today you can call me Angela. But on a normal day, please call me Lynn. Now, we've had really great insights. We saw the video. We've heard from Daktari around the evidence that has come out of this session. But even before we go into that evidence, I want to reflect on a couple of things. Some of the themes that are coming across from even the other sessions in this summit. One, we are acknowledging there is need to invest in human capital and social development. As a country, as a continent, we really must develop our human capital. Two, reflecting on the data, the statistics, we have, and correct me if I'm wrong, more than 77% of Tanzanians being below the age of 35. So there's a huge group that if we do it right, we will sort so many things for Tanzania. Three, we also know that youth are not homogeneous. So we have special groups within this grouping that we call youth that require perhaps very different interventions. Four, evidence also shows us the postpartum period is very critical, not just for the mother, but also for the child. And five, we also know, unfortunately, for first-time mothers, the first-time mothers age 15 to 25 are sometimes the most difficult in accessing health services, yet we really must reach them. It is for these reasons that we sought to find out, can light touch enhancements, we are layering this work on ongoing initiatives. Can those light touch enhancements generate the impact that we want? And I am so happy to say that even those light touch enhancements, and it's light because people like Madam Rosa there are already doing so much work. The health system is already set up to do so much more. But can a light touch enhancement give us significant results? So it is based on this that I want to invite our panelists to reflect on those findings, but also to reflect on what we are doing for adolescents in Tanzania. So my first question to Dr. Makuani, very generally, tell us what is the situation for reproductive, maternal, newborn, child and adolescent health in Tanzania? And what do you see as the key priorities and challenges in advancing RMNCH, especially focusing on scalability and sustainability of both community and facility interventions? So very generally, you can tell us what that situation is, then perhaps reflect more on the priorities and challenges in advancing these different interventions that we have that have a lot of evidence. Karibu Daktari.
Thank you very much for that humble introduction, and again inviting me to try to contribute what is going on RAMCA in Tanzania. First of all, I'll talk on policy side, and secondly, I'll share some of the experiences. I have a niece 4 years ago. She was pregnant while she was Form 2. She was in Form 2. So I thought this niece doesn't deserve to go without education. Last year, I wanted to take her to vocational training, just to learn. As she was in the vocational training, she was again pregnant. And those are the realities on the ground. Those are the realities you need to deal on the ground. So she's one of the contributors of numbers of teenager pregnancy. And the recent data shows that our teenage pregnancy is around 22%, which has dropped a bit from 27% that was reported in 2015. And so as from 29% that went to be reported in around 2010. So the situation remains to be challenging, and this varies from one region to another. While the numbers are too big, when you go to Lake Zone, for example, the teenager pregnancy is extremely very, very high. So as when you go to Southern Highland Tanzania as well, the numbers are too high. Reducing a bit to when you go to the coast regions. It goes down, but again, there are so many girls, again, they missed the opportunities. Where I come from in Southern Tanzania, use of the depot to teenager is a libero. But that is not the case for many parts of Tanzania. Again, we have the policies which are guiding that. We have interventions like one plan 3, we have a bigger portion whereby we are talking about issues of teenager pregnancy. For those bookworms, if you read the 5-year development plan, the last 5-year development plan, national development plan, they're about something like 29 words on fertility. If you search them, you will find them there. There are so many. So in terms of policy, Tanzania understands we need to address issues of adolescents. We need to address issues of fertility. What are the challenges? The challenge is we have our beliefs, we have our culture, and those differs from one region to another. But again, issues of education. Let me tell you, the biggest vaccine for issues of controlling fertility is education. If a girl is able to stay in class for more than 25 years, that means they are likely the first pregnancy will be delayed. So the question is to ask ourselves how much girls we have managed to reach them with their very comprehensive education. And so as how much girls and boys we have managed to reach them with the comprehensive sexual education, which we are told is the best in Tanzania. The question is, how is it implemented? So when you look at it, the players for issues of adolescent girls and boys is not only the health. Why the health is participating in those areas which are related to it, like family planning and so forth. But there are people in education, community development, issues of industry, and how economic empowerment of girls and boys. Those are key issues that needs to be addressed. And that's why the nation developed another document, which is called NAHIA, National Accelerated Agenda for the Adolescents and Well-Being, which has 6 pillars. The first one is prevent HIV. The second one is prevent teenager pregnancy. The third one is an issue, I think it is to deal with GBV. The fourth one is about to enhance good nutrition. The fifth one is about to prevent dropping from schools. And the fifth one is giving an enabling environment for economic growth. And when you look at that document, the signatories are many ministries, showing that this is a cross-cutting issue. So when we address, if we want to very comprehensively addressing this matter, not only looking at the health, we need to look beyond the health. We need to look at education, industry, economic empowerment, and et cetera, et cetera. Maybe I stop there, showing you so that others can show the way towards discussing this matter. Thank you.
Asante sana, Dr. Makuani. I will come back to you because I still want to explore the issue of scalability and sustainability. But before we do, I want to invite Dr. Kengia to tell us, we heard he's a primary care expert with many years of experience. So, similar question to what I posed to Dr. Makuani. Dr. Kengia, tell us, what is the situation of primary health care, especially across RMNCH services? Karibu.
Thank you very much for that very good questions. And it's really evident that if we want really to achieve the universal health coverage, and even the subject of the topic that we're talking about today, we cannot really run away from the primary health care. Primary health care is the gateway for the services. So in line with what Dr. Makwani talked about, the role of intersectoral collaborations, but of course we need also to think about how can we strengthen our PHC system, primary health care. And in particular now I'm talking about we cannot run also away from the what is advocated by the WHO, the 3 service delivery model. Number 1, how can we really improve our facilities to be able to offer all those services? And here we're talking about the family planning. But number 2, the issue of the component of outreach services. But number 3, the home-based visits. And in line with what was shared today, in agreement that we really need to invest in building our health system, our health facility, to be able to now offer the services, the family plan. And it's evident from our setup that at least we're able now to offer these services from the dispensary levels, health centers and district hospitals, depending on the package of care in line with the existing guidelines. So we really need to further invest on that one. And in particular now, for facility levels, it's very, very important now to ensure that the service must be available. Because before utilization of the service itself must be available at the level of the facilities. And now to be available is all the aspects of services, the commodities, but also people with capabilities. I'm talking about here the capacities to be able to offer those services. And in line with our discussion today, we've seen the importance really of keeping our healthcare workers in terms of knowledges on how to really handle those women, first-time women that are coming to our facilities. The issue of confidentiality is important. Of course, handling them with respective care, all those are very important. So giving them additional training is critical so that can be able now to handle properly those women who are coming in our facilities. Of course, within our facility also we need also to have facility areas for adolescents and youth-friendly services. But when they are coming there, they really should feel comfortable to be able to receive the appropriate care. Of course, investment into the community level is also important. And the good news is from the yesterday during the open, we heard from the Minister of Health, the component of community health workers. We also need to invest on that one to see how best can we really utilizing them for further demand creation in the communities, so that we can have the women coming in our facilities. But of course, you can think more of a different package for the CHW so that we can improve the community aspect. Here talking about the home visits for demand creations, and of course, health educations, of course, optimize the issue of how can we engage the wider communities, and even the component of male involvement so that you can have them at part and parcels to improve the issue of family planning. Thank you very much.
Asante sana, Dr. Kengia. Thank you for reminding us, even when we are providing services to youth, there are certain things that will move the needle regarding, respectful care, confidentiality, etc. You mentioned universal health coverage, and actually that was one of my questions, so it's a brilliant segue. How are the needs of adolescents being addressed in the universal health coverage? Dr. Kengia.
Thank you very much. Actually, when talking about universal health coverage, you are talking about 3. First of all, the issue of coverage is important. We must have a coverage, the coverage of services. So within the supply sides, we need to ensure that we have really the service that is available. Available quantitatively, but also qualitative in terms of the quality. That is important. The second component of universal health coverage. Access, 1, 2, quality, but 3, of course, we must ensure that they receive those services without financial constraints, issue like catastrophic case expenditures. And now, starting from the last one, of course, catastrophic case expenditures is, you could have it in 2 ways. One is to pay, and the second one is the issue of the transportation costs and the likes. So for family planning services, I will dwell more on the issue of reducing the transportation cost So we need there to find a way, a mode operandi that you have the services that is made available closer to the people. And it can be closer to the people through improving the access in terms of the facilities that are offering the services. But point number 2 is to bring the service close to them, so that you can now reduce the transportation cost. Of course, quality and the issue of access, I already talked about it in my earlier talk. Thank you.
Asante sana. Dr. Thomas, karibu sana. We know you're the DMO for Congo Council, and Congo is one of the councils that was implementing this project. I'm curious to hear from your desk, from where you sit, what are the lessons learned implementing this evidence-based approach for first-time mothers?
Oh, thank you very much. First, I should appreciate being in this meeting, which is very important for the reproductive and child health development.
Can you hear me? Hear him?
Hello? Yes. Yeah. Being in Congo and implementing the project together with the Save the Children through this Connect project, we have been witnessing a lot of changes. First, Save the Children and the Connect project has been one of the contributors towards dropping of that is 2015% of teenage pregnancy from 39%, and currently is 24.2%. So, together with the government working upon it and the other stakeholders, we are glad that the Save the Children has been part of it through that Connect project. So, we really appreciate that this evidence-based practice through working in facility in the community is part of the way to improve these teenage pregnancies improvements. We have been working a lot through the facility projects. Working through those healthcare workers working through the facilities. But the project has been working in leveraging the community and the facility through working with community health workers who have been, which is also a priority for the government currently. The government is now working upon employment of community health workers, working through, when you want to reduce maternal mortality and perinatal mortality, it is not just only in healthcare workers only. It's multifactorial. It's multisectoral. It has to involve the facilities. It has to involve the community and the community leaders. It has to involve the stakeholders, and it has to involve donors, because the government cannot do it alone. So we have just see the total change. We can see the improvement. Now, with regard to family planning, what we have in these teenage pregnancies, as we have seen, is still a challenge, because the uptake for family planning in Congo currently, for those newly registered, is 39.2%. Of course, they're approaching the national average of 40%, but it's still low. But also the total women of reproductive age consuming family planning services, we are in 64%, which is at least above national average. But it's still a problem, because we can see a lot of teenage pregnancies is still there. You can see 24% is still a significant number, which we still need to work upon it and work on it collaboratively with healthcare workers, community, and the stakeholders who are going to deal with this. Thank you.
Asante sana, Dr. Thomas. Great lessons there. And you're reflecting on the journey for the last couple of years, but the funding ends this year, right? So I want to put you to task. As the DMO for Congo Council, there has been capacity building. You've seen the evidence. What is it that you can do from where you sit that will ensure that all this work was not for granted? that it continues.
All right, thank you very much. You can see reproductive and child health is one of the second priority intervention in our comprehensive council health plans, which is in the council. So we put more weight on reproductive and child health services compared to other services, as we see it is a problem to our country and Congo in particular. So even if the project ends, and I believe we are working with other stakeholders also who have been also doing this. This project ends, but we are going also to put it in our comprehensive council health plan budget, because we need even to put them to be sustainable. Also, we are going to work, because we are working with the community. We want the community to put this issue of family planning services as part of their big agenda in their meetings in their community. So because we use the leadership in the villages, we use the leadership in the wards, we are going to strengthen the communication between the council leaders and the community leaders, I mean those councillors and the village workers, and the village government, to strengthen the use of family planning services together with other reproductive and child health services. So it has to be integrated with other services which are offered in that area. So we are in doubt, because we still have more challenges which are there, and we still welcome other stakeholders to work on this, because as per yesterday, if I understood it clearly, the emphasis was government and private partnership, public-private partnership. So we don't need only to sit alone to work on this, because teenage pregnancy is still a challenge. We need to sit together again with the other stakeholders who would be interested to come to Kongwa and the other district of Dodoma to work on this, that we can sit together and work together for sustainability purpose. Thank you.
Asante, Dr. Thomas. Gerald, I could see you smiling, so I want to put you on the spot. We've been reminded that adolescent health requires multi-sectoral engagement. We've seen very many interventions that are evidence-based. A lot of evidence is generated, but I want to pick your brain a little bit on you as the National Coordinator for Gender and Adolescent Health. How do you support the different stakeholders to ensure that all this evidence is taken up, is scaled up, and is meaningful for the country?
Yes, thank you. Being a national coordinator at the Ministry of Health, actually, we are having the technical working group, the National Technical Working Group for Adolescent Health and Gender. It's regularly quarterly basis. That's the platform where all stakeholders who are implementing around the SRH, we meet together and discuss the best practices, the challenges, and the lesson learned, and coming together with the agreed action to work on so as to improve our interventions, to improve our challenges that's hindering or challenges that are facing our adolescents. So we have various platforms that most of our stakeholders meet together and discuss the challenge that we are having together, including the adolescents themselves, so as having the responses that respond to the real needs of these adolescents. So we have those kind of platform that actually serve as a purpose to bring together all stakeholders and partners to address the issues around the adolescent and the sexual reproductive health. Save the Children being part of them, and actually even the intervention of first-time young mothers, to me it sounds like the innovative interventions, because being a mother at the teenage age itself, it's a challenge, and it has a lot of implication in our community. So we have to create a space, a safer space for these young mothers and young parents. They can feel, so they can feel at least they are respected with their respective care, but they are treated uniquely at the client. And we all understand our setting, our clinical settings, actually they are like adult-centered. So we are trying in our level best to make sure the clinical setting should be friendly enough to respond on the needs of this adolescent, specifically to these newly mothers or the young mothers.
Excellent. Now, there's one story that we must not forget, and one voice that we have to hear from, and that is Rosa's. And now, because Dr. Makwani, you're next to me, I will put you on the spot again. You're going to translate this for me. We are going to ask Rosa to share her experience reaching young mothers in the postpartum period and for nutrition. But also because there's a captive audience here of different stakeholders. We want to know what is her ask as a community health worker, addressing all these different stakeholders and speaking on behalf of community health workers. What is her request to the different stakeholders? You're going to translate for me? Here you go.
Anasema wewe ukiwa mtoa huduma ngazi ya jamii, umewezaje kuwafikia hawa akina dada wanaopata ujauzito katika umri mdogo baada ya kujifungua na masuala ya nutrition? Hilo ndio swali lake la kwanza. Lakini na masuala ya lishe, kwenye masuala ya baada ya kujifungua, huduma baada ya kujifungua na masuala ya lishe. Hilo ndio swali la kwanza. Swali la pili anauliza umewezaje kufanya kazi na wadau mbalimbali katika kuhakikisha hizi huduma zinawafikia hawa walengwa, na una ujumbe gani katika hadhira hii, na kitu gani ambacho ungependa wafanye ili huduma zako ziwe bora?
Asante. Asante. Kwa jina naitwa Roda Chimagai kutoka kijiji cha Chirunguru, kata ya Mdemu, tarafa ya Mdemu, wilaya ya Bahi, mkoa wa Dodoma. Mimi ni mhudumu wa afya ngazi ya jamii. Nimeweza kuwapata hawa mama vijana. Kwanza kabisa nilipokuwa natembelea kaya kufanya sensa, niliweza kuwabaini hawa mama nikawapata. Lakini nimeweza kuwapata hawa wamama nilipokuwa nahudhuria kliniki za wamama wajawazito, mama na mtoto. Mimi nilikuwa nahudhuria na wasaidia manesi kule, niliweza kuwapata hawa wamama vijana. Pia nimeweza kuwapata hawa mama vijana kwa kushirikiana na wakunga wa jadi wa maeneo yao kwenye vitongoji. Nimeshirikiana na wakunga wa jadi ili nimeweza kuwapata wamama vijana. Ninavyoweza kutoa elimu ya lishe. Elimu natoa nikiwatembelea majumbani, nikiwa na bango kitita. Lile bango kitita nalenga nyumba ile ina mtoto wa aina gani na kuna tatizo gani. Naenda nimepanga kuwa nikienda kwenye nyumba ile nitatoa mada inayolingana na tatizo lao. Kwa hiyo natoa mada kulingana na tatizo lao ambalo wako nalo. Kama ni uzazi wa mpango kwenye mama ambaye familia zinazaa haraka haraka, kwa hiyo naenda nimejipanga ili niweze kuwaingiza kwenye nia ya kutumia njia za uzazi wa mpango. Kwa hiyo niliweza kufanya hivyo. Pia kwenye lishe nimeweza kutoa elimu kwenye lishe kwa kuonyesha mifano ya vyakula ambavyo wanavyo majumbani au vinavyopatikana kwenye jamii kutoka kwenye makundi yetu yale 5 ya vyakula. Makundi 5 ya vyakula. Kundi la kwanza ni nafaka, mizizi na ndizi za kupika. Lakini kundi la pili limegawanyika sehemu mbili. Sehemu ya kwanza ni jamii ya mikunde ambao kuna maharage, njugumawe na nini. Kwa hiyo njugumawe zinapatikana kwenye jamii. Lakini kundi la pili hilo kwenye sehemu ya B kuna asili ya wanyama. Asili ya wanyama tunapata nyama kwenye nyama za ng'ombe, nyama za mbuzi, nyama za kila aina. Pia tunapata bidhaa kama vile maziwa na mayai kwenye kuku. Kwenye la tatu ni mboga mboga, na la 4 ni matunda, na la 5 ni asali, sukari na mafuta. Kwa hiyo ndo mafungu yetu 5 ya vyakula. Kwa hiyo nawafundisha haya mafungu, wachukue fungu kwenye fungu la kwanza kwenye nafaka, mizizi na ndizi wachukue fungu moja, na kwenye fungu la pili wachukue kitu kimoja, na kwenye fungu la 3 na la 4 na la 5 hivyo hivyo, kutokana na vitu walivyonavyo wenyewe kwenye jamii. Kwa hiyo nilikuwa nafanya hivyo, na wakati mwingine nilikuwa nafanya elimu kwa vitendo. Naenda nasema hivi vitu unavyotoa tunatengeneza pale, na mwenyewe anaona, familia inaona. Kwa hiyo tunatengeneza, ndio maana niliweza kufanikiwa elimu yangu.
There was a second part of that question. Dr. Thomas, you can translate that one because you're holding the mic. The request to our wadau wote.
Nashauri nini?
Nimesikia. Mimi nashauri wadau, hata kama huu mradi wa Connect utatuacha, lakini miradi mingine ije vijijini, ione tatizo la vijijini ili iweze kusupport jamii iweze kuendelea, na hii elimu iwe endelevu kwa vizazi na vizazi, kwa sababu tukiacha hivi vizazi vitarudi nyuma. Kwa kweli tulikuwa tunapata shida, watu walikuwa wanazaa mtoto mdogo ana watoto 7, 8, anashindwa kutimiza malengo yake. Kwa hiyo pia na waasa wahudumu wenzangu, hata kama tunafanya kazi kwenye mazingira magumu, mazingira ambayo kweli ni magumu. Mnavyoniona hapa mimi nimezeekea kwenye uhudumu wa afya, lakini nimekumbana na mambo mengi, na kuna baadhi ya wengine wananicheka, hivi huyu huko anapata nini wakati anadidimia kimaisha? Lakini mimi nakubali kuiokoa jamii yangu, kwa sababu nilikubali kwa hiari yangu ili nikomboe jamii. Ndio maana nawaomba tushirikiane kwa pamoja na hawa vijana wetu ambao ni wahudumu wa afya vijana, waige moyo wangu na moyo wa wenzangu wahudumu wakuu, ili waendeleze, angalie masilahi, wafanye kazi kwa kutetea jamii yetu.
Those who are in the audience and think Madam Rosa is an excellent teacher and we thank her for service. Clap your hands with me. So now for the next session, I know there are a few questions in the audience. We have a group of stakeholders here that we really want to engage on matters of adolescent health. So I'm going to ask Victoria to help me, and Amani and the rest of the team to help me with the mic, roving the mic, so that we ask the questions to these key stakeholders.
Yeah, thanks for the chance. May I mix the language for the help of my mother. Kwanza napenda kumpongeza sana kwa huduma ambazo ametoa. Naitwa Machimani Kiwanga, natoka Chuo Kikuu cha Dar es Salaam. Ni mdau wa vijana na mkereketo wa vijana. Pia ni mwanafunzi wa PhD katika Medical Tourism, utalii tiba. Nafanya Chuo Kikuu cha Dar es Salaam na Open University of Tanzania. Kongwa pia nimeoa Kongwa. Kwa hiyo ni kwa wakwe zangu. Sasa mbali na hivyo pia nishafanya kazi local government kama mratibu wa afya mashuleni nikiwa wilaya Monduli. Na katika maisha yangu ya ujana nilikuwa napenda sana kufanya kazi maeneo magumu ili nione matokeo yanavyotoka. Sasa kuna swali imeulizwa pale na moderator kwamba baada ya Save the Children watakavyotoka nini kitakachofanyika baada ya hapo. Mganga mkuu akagusia kwamba ataendelea kuhusisha wadau mbalimbali. Ni kweli. Na mimi Monduli pia nilikuwa ni PPP coordinator, public private partnership. Na katika level ile kweli inahitajika wadau mbalimbali. Hata Monduli changamoto ya watoto kupata ujauzito wanafunzi ni kama iliyopo Kongwa. Na huwa nafuatia hiyo data katika ile eneo. Kwa hiyo naomba pia nimtie moyo mganga mkuu kwamba program za vijana na watoto katika jamii sio za kwako peke yako. Kuna viongozi wa dini kupitia kwenye organization zao wanaweza wakawa wanachangia. Kuna hata wale viongozi wa kimila. Tulikuwa tunakutana na malaigwana ni kule Umasaini. Na habari nzuri pia nilifanya kazi hata mkoa wa Pwani na watu wa Kenya International miaka 2000. Kuna wale hata waganga wa jadi ukiwashirikisha, na bahati nzuri Wizara ya Afya ina kitengo cha tiba mbadala. Kwa kuwashirikisha wale wote tunaweza tukafanya kazi kwa pamoja. La pili, voluntarism ya mama. Nafikiri uongozi wa halmashauri unatakiwa kuendelea kuibua community owned resource persons na kuwapa empowerment. Mama alikuwa anachambua hapa nutrition katika level ya chini kabisa kwa vyakula vilivyopo katika ile jamii. Sasa kitu ambacho ni katika ground. Kwa hiyo napenda sana kumpongeza katika hilo. Nashukuru sana.
Asante sana. Those were mainly comments. And nitaomba we keep our comments and questions very brief, no, we can take as many as we can. Asante sana.
Asante, thank you, and congratulations all the panelists for a very good presentation. I have two questions. One goes to Dr. Makuani and the second one to Gerardi. To start with Dr. Makuani, I know as has been said, once we increase the family planning uptake, it's more likely we reduce the chances for maternal death. And one among the obstacles, I've been working in a lake zone for about 10 years now, is the issue of male dominance. Male engagement is the key. Kwa sababu kila ambacho mama anataka kufanya lazima kiwe authorized na mwanaume. So what has been done so far to enhance the male engagement or involvement interventions, and what challenges that we've seen on the ground so that school adolescents and the school adolescents. We have a number of interventions for the out-of-school adolescent boys and girls. But the challenge is for those who are currently in school, especially on the sexual reproductive health education. We know we've seen a number of school dropout due to the pregnancy. So what kind of interventions have been proven to be successful? I know you've been coordinating intervention across the country. expected to reach the adolescents who are in school and to ensure that they have access to the sexual.
Okay, thank you. Dr. Anosisi Kesale, I'm a country lead for the USAID Local Health System Sustainability Project. My question goes to DMO, and then I wanted to ask that, okay, for the sustainability purpose, because we have seen here, mama alivyokuwa anaongea pale, kwamba they need support, even to motivate and provide incentive to the CHWs for the great work they are doing. What are the initiatives that have been taken maybe by the Kongwa District Council to motivate and incentivize the CHW? We know where they are working, tuna serikali za vijiji, tuna health facilities, they have their budgets. Have you maybe tried to integrate their incentive to their budgets so that hao akina mama waendelee kufanya kazi kuna mazingira magumu? Thank you.
Asante. One more question and then we come back to the panel.
Vanessa Paul from University of Dar es Salaam, DDS student. I have a comment and a question. I'm also an Youth Associate Ambassador for the UNESCO project O3 and O3+, advocating for SRHR, HIV and AIDS in adolescent boys and girls in the 17 beneficiary universities, which includes University of Dar es Salaam and all its campuses and University of Dodoma. So in the UNESCO project, UNESCO offers comprehensive sexuality education online course, and this online course is 6 months maximum, but you can study it anytime that you want, and you can complete it anytime that you want, and then when you complete, you are awarded a certificate. It's a very comprehensive course, and it is facilitated in these 17 beneficiary universities. But also there is another course in the basic primary education by the name Life Skill and SRHR Education, also under UNESCO Dar es Salaam office. So my comment is, I have been in this project for the past 2 years, and the challenge is this course has been there, but the adolescents are not really ready to study it. So you might find in a college with 600 students, only 35 have registered and they have completed. That is less than 10%. So we were actually analyzing, and we came across some factors which may be associated with. So we actually identified there is late adaptation for these services and these courses, because when we were actually assessing these adolescents, they said they never had this education prior before coming to the university. So they view it as something new, while others had education which was not appropriate. So they had knowledge which is not appropriate. So I think the government should work on early adaptation, and not just early adaptation, but also early effective adaptation of these CSE courses, especially in primary schools, as it is doing now, but more influence, and the effective delivery of these courses, because you might find very many youth online, but then they won't do that course. They will do something else which is not as important as that course is. And my question is, I've also been doing research on family planning in Mbeya region, and my last research was on family planning knowledge, attitude, and practice among married men in Mbeya. And actually the results were surprising, because men had a lot of knowledge on women family planning methods, while they knew little about the male family planning method. And worse is when it comes to practice, because among 106 men, only one man had a positive attitude of vasectomy. So the situation is not good. So actually my question is on the issue of knowledge. We have had these studies of knowledge, attitude, and practice, and we have had that knowledge is really high, but when we do these studies, we use different questionnaires to assess the knowledge, and we don't have a standard tool that can actually assess the knowledge and give us a magnitude that is universal for all of us. So I would urge you to to Dr. Makwani. Yes. Could we have a standard knowledge questionnaire or something for family planning? Because it has been a challenge. We are just hearing family planning knowledge is really high, but also my other study on contraceptives among young women showed that almost 43% of the women knew only less than 3 methods of family planning, while the knowledge part had 95%. So that is actually really surprising. So they have knowledge, but you do not know the actual extent of the knowledge that they have. Thank you.
Asante sana. So we'll take that round of questions. Dr. Makwani, there are 2 seemingly related questions for you. There was a question around male engagement, but also in terms of male FP methods, which is also tied to the question around the standard questionnaire for FP knowledge. There was also the question around incentivizing CHWs for Dr. Thomas. Adolescent interventions for those in school for Gerald. Yes, I think those are the main questions for this round. Karibu.
Asante. First, there is this question about what is next. I think
yes.
I need also to try to answer it on policy perspective. I think you have read about a unified community health worker approach. And I think Dodoma is one of the priority region. Therefore, all those services whereby Rose is providing, they are likely to be covered with that system.
Yes.
But the approach says, don't leave behind those who were there. I think this is the instruction we are given as a local government. Do not drop CHW. CHW wale waliokuwako wakati ule lazima muendelee nao na hawa kina Rosa wawasaidie kupasi hiyo knowledge and skills za kumanage vitu hivyo. Nadhani hiyo mmeisikia. There was a question which was asking to increase family planning to reduce maternal mortality. What have we done so far to involve community? Unfortunately for Tanzania, the maternal mortality sharply was shown to be reduced. But you can't tie it with the increase in family planning. Actually, it shows some stagnation, if not decline. So there are other factors that needs to be considered there. But I want to approach this question. The emphasis is pass all facets of the community entry. Community leaders, we used to involve them. For example, here in Zanzibar, I know shares are very much involved in issues of family planning. When you go to other, they get the services. Because even when you look at the data, you'll find that unmet need is high still. There is demand issue, there is an unmet need issue, meaning that we have not reached some people. I happened to reach some women. They said, you know, here in order to get family planning, until those people, they come after some schedules. Otherwise, it is extremely difficult to get the services, meaning that many women are not reached. They demand, but they are not reached. So that is an area that we need to ensure that we use all the facets to reach the community. A standard questionnaire of FP. Madam, this question, I think, that is in short that what I would say.
Asante sana.
But maybe connect with us so that we can give you a standard questionnaire.
I'm being reminded that our time is up. So as you respond, please make it also your parting shot. So 30 seconds or less.
Thank you. Rick, I can respond. The question from Kesale. What are we doing to make sure that these community health workers are working comfortably. Yeah, throughout we have been dealing with recognition, first recognition, because these are the community health workers, but they are not community workers. So we have been working clearly to make sure that they are being recognized at the district level and at the community they live. It was very difficult for them to be recognized by the community or village leaders. So we have been dealing with that. Again, we have also been involving them in our budget. These are they are very rich in knowledge because we have them in our budgets and we go do outreach services with them, and they help us in RSH services also, especially in weighing our children and other services which they can do. Again, we have decided, thank you. Yes, shorting. I have shortened. We decided it to involve them, to pay community health workers, for community health fund, to pay for them. In Kongwa, we decided to do that we need to pay the community health fund for them, that they can get their treatment and the health facilities with very minimal cost and cut off that catastrophic payment. Yes. With all others, we also encourage other stakeholders who will be coming to Kongwa, and we also accept what Dr. Makwani has said. We are not even to live. We are not going to live behind this. You can say, how can you live behind somebody like this in healthcare workers, in healthcare perspective? Thank you very much.
Gerald, there was a question for you as we part. You're parting short as well.
Yes, on the issue of male engagement, where are we? Actually, we have developed the national guideline for male engagement. Then soon we are expecting to do some disseminations and orientation on it. And on the issue of school adolescent, the in-school, yes, there is some interventions going on. The CSE, Comprehensive Sexuality Education, though there is some challenges with the education sector, but with this, the life skills manual, we hope for the good. And currently, I'm told they are trying to develop the CSE for the secondary school. They are in Morogoro now. So there is a bright future. So the CSE will be the way to go. And on the adaptation of the O3 Plus, the UNESCO, yes. Again, we have developed the national framework for higher and tertiary learning institution for establishment and the provision of STI, SRH, HIV and GBV in higher and learning institutions. We hope for sustaining the gains from the O3 Plus. With this framework, probably will sustain the program.
Asante. Now I hand over to my leader here to close the session.
So we stand maybe so that we can let the others come. First of all, I should thank the Save the Children group and their partners as well. And I should thank our colleagues from Dodoma Bahi. Asante sana Rosa for coming, kwa kuja na kukaa hapa na kutoa jinsi ulivyoweza kuzungumzia shughuli zako kule. Umewasikia watu wengi wamezipenda shughuli zako na tungependa hizo shughuli ziendelee. Lakini niwashukuru sana panelisti wenzangu kwa kuifanya hii mada iwe na nguvu, na tuwashukuru wote ambao mmekuja kusikiliza, na kwa nafasi zetu hebu tuangalie namna gani tunaweza kuwasaidia wananchi wetu, lakini namna gani ambavyo tunaweza kuwasaidia wenzetu wa Bahi. Asanteni sana.
Asante sana panel yote. Napenda kuwakaribisha kwenye booth ya Save the Children. Tuna interventions zaidi za kujifunza, lakini zaidi sana tunaweza tukajifunza kuhusiana na kuintegrate ECCD, Early Childhood Development kwenye health programs. Karibuni sana, asante.
Session here, which will start now. USAID PS3 Health Forum. So you can stay for the session, because after that session you will go to the main hall for awards, then cocktail. So you can also stay here and continue with the next session. Thank you.
Gerald, see you. Okay. Look, I need to come visit you one of these days.